All right, welcome everybody. I'm very excited to have the opportunity to introduce our panel. My name is Miriam Kamarami. I'm one of the associate directors of the ECHO Institute here in New Mexico. When you think about who is the primary person who the ECHO model serves, it is really the brave, smart, hardworking, and inspiring folks who deliver primary care in this country. They're who we're here to help. Our other biggest customer is the patient, and specifically we're focused on care of traditionally underserved patients. When you put those two together, what you get is federally qualified health centers in this country. FQHCs are the primary deliverers of health care for folks who are traditionally underserved in this country, and they're really the heart of primary care in our country. As you've been hearing this morning, team-based care is evolving as the most appropriate way to deliver care in the primary care setting. And within ECHO, our evolution has also focused on team-based care. Originally, when the ECHO model launched, we were thinking about the physician, maybe the nurse practitioner or the PA. Over time, we've realized that primary care delivered well truly is a team sport, and that we need to be involving the whole range of folks who are important players in the team-based sport of primary care. I'm very excited to introduce this panel, which will be led by Tom Bodenheimer. Tom is an internationally recognized expert in the science of primary care and understanding how do we deliver primary care well, how do we deliver really high quality care within the primary care system. And he has particularly been focused on team-based care in recent years and has published very widely in this area. So we're so fortunate to have Tom here to moderate this panel today. So without further ado, let me introduce the panel, which is entitled, For Federally Qualified Health Centers, Healthcare Can Be a True Team Sport. Tom?
Thank you, Miriam. Can everyone hear me? So I want to start out by asking all of you a question. You could just shout out the answer if you know it. What is the fifth guiding principle of the ECHO movement? Team-based care. Okay. So let me introduce myself. Just one more thing, that I was a practicing primary care physician for 32 years in a low-income community of San Francisco. I'm now at the Center for Excellence in Primary Care at University of California, San Francisco. Over here is Chris Ruge, nurse practitioner with years of primary care clinical experience, particularly managing patients with complex healthcare needs. He is at El Centro Family Health, a federally qualified health center in Las Vegas, New Mexico. Bob DeFelice, Master of Public Health and MBA, has a long history working with vulnerable populations and communities in New Mexico. He's currently CEO of the First Choice Community Healthcare, FQHC, with 8 sites in 3 New Mexico counties. Roger Chauffournier has a Master of Health Services Administration and is now CEO of CSI Solutions, a consulting firm that assists practices in their transformation. So we have the viewpoints of 2 primary care clinicians, a health center leader, and a practice consultant with a national perspective. So that's who we are. So first, what I'd like to do is to set some ground rules for this panel, because really good teams set ground rules for themselves as to how they're going to work together. So number 1, ground rule number 1, this is a conversation, not a series of speeches. Ground rule 2, we want all of you as attendees to participate. So in the second half, we'll open it up to questions for you. Ground rule number 3, now the people on this panel and in this room have enough knowledge to talk for hours and hours about team-based care. We don't have hours and hours, so I'm going to have to manage the clock. So ground rule 3 is managing the clock, and we'd like both panelists and attendees to stick to allotted times. And for all of you, when you ask questions, please speak for a minute or 2 or less. And also, when we answer your questions, we will try to be brief. The main purpose of this is to give everyone who has something to say a chance to say it. Now, to implement these ground rules, I have brought some chimes. For panelists and all of you who go over your allotted times, you will hear these beautiful sounds. And you will stop talking to listen to this music. Okay, the first thing I'm going to do is to break the ground rules. And I'm going to give a little talk. But it's not very long. So I want to talk about what we have learned at the Center for Excellence in Primary Care about teams in very high-performing practices. So the first, I want to ask you also more questions. So building teams is not so easy. So why bother to build teams? So I'm going to ask all of you, please raise your hand if you've worked in some way, shape, or form with a primary care team. Okay, now we're going to talk a little more about primary care here. I think a lot of the discussion of teams has been included to primary care plus specialists. I think we're going to talk a little bit more about primary care teams. Another question for you. Did any team members independently care for patients without clinician involvement? Now, by clinician, I'm using clinician to refer to physicians, nurse practitioners, and PAs. So non-clinicians would be nurses, pharmacists, social workers, community health workers, medical assistants. In the places that you have worked with teams, did any team member independently care for patients without clinician involvement? Raise your hands. Not as many hands as we would like. That needs to improve. Did any team improve any quality measures over what a lone clinician could do? How many people have found that? Okay, more hands there. Maybe I'll look over here. And finally, did the team add capacity to see more patients? So we know we don't have enough primary care clinicians in this country. We may never have enough. So we're going to need all team members to step forth. So if the answer to all these questions is no, one would wonder what's the purpose of the team. So let me talk about what the purposes of teams are in these high-performing practices that we have visited. So the overall goal of the team really is to improve the health of the team's panel of patients. And then there's specific goals: to improve access by adding capacity, to improve quality beyond what a clinician alone can achieve, to create a comfortable, small practice environment for patients, very important, to reduce clinician burnout by having all team members engaged in the patient care, and to engage the entire team so that the entire team really is working in a meaningful way to take care of the patients that they're responsible for. Now, in these practices that we visited, what we found is that high-performing teams had 9 elements to them. That's a high-performing team. Stable team structure, which we're going to talk about a little bit. Co-location, culture shift, share the care. And then there's some other elements that we're not going to have time to talk about, but I talked about in the paper that's under the 2 pooches. So let me talk for a little bit about stable team structure. And this is really specifically primary care, but it could work for specialty also. So this is a team structure we noticed in many of the high-performing practices we visited. There's small teamlets within a larger team. Now, a lot of the teamlets were 2-person teamlets. A patient panel was impaneled to a clinician and a medical assistant. Sometimes they're larger, like in the VA, the teamlets have 4 people. And around several teamlets are more people for patients that need more help. So what do we mean by stable teams and stable teamlets? And the stability is really an important part of teamwork. Number 1, the same people always work together. Number 2, patients impaneled to a team or teamlet are always cared for by that team or teamlet, and the team or teamlet only cares for its patients. So what we see in practices that are not working so well is that people are shifted from one team to another for scheduling reasons, or that patients are seen not by their team but by a different team. That does not work very well, and that's not what you find in high-performing practices. So the teamlet structure is really helpful for patients because patients, research shows, prefer small practices over large practices, and in fact, what's happening in primary care is practices are getting bigger and bigger. So the teamlets convert these larger practices that are somewhat impersonal to small places where patients can feel comfortable and that patients know their teamlet members and the teamlet members know their patients. For clinicians, small teams are also very helpful because working in stable teamlets is associated with lower burnout rates for clinicians compared with working in teams with shifting personnel or no teams at all. Then the second thing I want to talk about besides the structure of the teams is the culture. And this is really going from I to we. That's what Project ECHO is all about. So we call it sharing the care. Now, sharing the care does not mean delegating tasks from, say, a doctor to a medical assistant. So it's not like a doctor saying, do this EKG or check this patient's blood sugar. Sharing the care is really reallocating responsibilities for the panel of patients that the team takes care of. So for example, say a team takes care of 1,000 patients. For these patients, let's say the medical assistant is responsible to make sure that all these patients have received all of their evidence-based preventive and chronic care routine services, for example, cancer screening, immunizations, and diabetes lab tests. The medical assistant is doing a lot for the health of that population of patients. That's what we mean by sharing the care. So to summarize, team has clear goals, for example, adding capacity to see more patients, creating a small practice environment. The team has a stable team structure, and team functioning is based on share the care, which is reallocating responsibilities for improving the health of the team's panel of patients. Okay. So we're now going to be having a discussion with the panel, and rather than people giving speeches, we're going to have a conversation like Sanjeev and Don Berwick had the last hour. So let me ask the first question to Chris. Chris, you've had a long history caring for patients with complex healthcare needs. So briefly, who is on your team, and are patients impaneled to the team so that the team knows which patients the team is responsible for?
So I think I'm one of the people the gong was meant to control here, so I better start. Basically, our team is set up. I'm the clinician, the primary care provider. I have 2 community health workers whose primary focus is social needs of our patients. They help them with everything from transportation, filling out forms, going with them to agencies, filling out housing forms, helping them get food, clothing, deal with landlords, really just hyper-focused on social, but also are my eyes and ears in the home as well. In addition to that, we have a registered nurse who acts as another clinician resource on the team and who helps me with things such as medbox pre-fills, again, disease management, disease education, health education in the home and in the clinic. And basically, as far as all the patients that are on our panel only work with us. They do no longer actually even call the clinic. We give them a separate number to call. It's available to them 24/7. When the clinic's open, it comes right to our office. Whichever one of us is in the office picks up the phone. They talk to someone they know. After hours, it goes to an on-call service, which has 24/7 access to me 365 days a year.
So it sounds like you have a team that the patients know who the team is and the team knows who the patients are.
Correct.
So So Bob, you're the CEO of a multi-site community health center. You have a bird's eye view of teams in your different sites. Maybe taking one of the sites as an example, who's on the team and are patients impaneled to the team so the team knows which patients it's responsible for?
Yeah, thank you, Tom. You know, our care team composition has evolved over the years, influenced primarily by fiscal, manpower, operational constraints, and changing community needs. Today at our South Valley Health Center site, our medical care team consists of a medical provider and a medical assistant. Care teams are supported by a site-based nurse flow manager, patient services representatives, a behavioral health specialist, pharmacy administrative assistant, lab assistants, referral specialists, medical records specialists, patient care facilitators, community health workers, patient eligibility site specialists, billing specialists, health center manager, and of course our Project ECHO consultants.
Okay, so are the patients impaneled to the team, and does the team really know? Could the team make a list of all the patients they're responsible for?
Yeah. With respect to patient empanelment, we currently have PCP, primary care provider assignments of Medicaid managed care patients, and are continuing to define how impaneling of our total patient population might work at First Choice.
Okay, so Roger, you've interacted with primary care practices all over the United States. What is the range of team compositions you've observed, and are patients generally impaneled to these teams?
Thanks, Tom. Yes, I think it's really important to note that we're changing from a traditional model where just a few years ago, Medical Group Management Association would report that the average amount of support personnel per provider was about 3.1 to 3.4. So that was typically a nurse, a medical assistant, maybe a front desk person working with a provider. The high-performing organizations, especially in the FQHC movement that I've seen around the country, have not just changed the team composition, but they've been very clear on changing the overall care model and moving away from just a focus on an encounter to what are the whole needs of the person. How are we engaging the person in the clinic and outside of the clinic? And to do that, they've rethought the staffing compositions. So typically seeing staffing now moving up as high as 5 to 7 to 1 support personnel per provider. But not necessarily all full-time, but in a composition. But really rethinking the workflows that support that work, and obviously this depends upon the local reimbursement and situation in the clinic. But it is a change process, it's iterative, and is dynamic. It's ongoing, reviewing the underlying staffing model and how is it meeting the patients. But the patients are impaneled. The work is spread across the care team. With two last points that I think are really provocative, far more of the higher performing teams are seeing moving a lot of work down to the lowest level allowed by scope of practice, so increasing the number of medical assistants as part of that staffing ratio, so more of that work being done. And then second, blurring of the boundaries of the organization. So beginning to include public health workers, community-based resources as part of the care team, as part of the huddles, as part of the dialogue owning the patient.
Thank you. So teams in 10 years and 5 years are going to look a lot different than teams look now, because we're going to have many more, hopefully, people to support the team. Right now, if you only have one medical assistant per clinician, the medical assistant really can't share the care to the extent that she could because there's not enough time for her to do that. So next question I want to ask to Chris again, which is, can you maybe give an example of how your team has made a difference for a patient or group of patients beyond what a clinician alone could do?
So yeah, thanks. So I've been doing this type of work for about a little over 21 years now, and really the way I've looked at it is everyone on the team brings something to the table. Many of our patients deal best with me. Many of our patients have their best relationship with the office manager, who answers the phone all the time and likes to call her once or twice a day. Other people have close connections with the community health workers, others with the RNs. It's surprising what people will tell different members of the team. It's just their comfort level, what they think that member is safe in releasing that information to. And I just look at all members of the team as my eyes and ears. So the more members of my team that are more engaged with the patient, it enhances our chances of being able to help the person. It also helps that person connect with someone on the team in a meaningful way. So it's all about relationships. As far as something that happened with one of our patients, and really probably most of the meaningful interactions and results come about because of another team member. I'm a vital part of the team. I love being able to contribute, but really there is no hierarchy as far as who is helping the patient more. In a particular situation, there was a gentleman I worked with for probably 4 years before our team started. Really persistent drunkenness, alcoholism. I never saw him when he wasn't grossly intoxicated over a period of 4 years. He actually fell off a wall on his birthday back in 2011, broke his back, is now a paraplegic, still did not stop drinking. I saw him within a day or two after rehab, and he was out of the acute care facility, and he was drunk again. When he started with us, he was living in what he called was a hunter's trailer, a small trailer with no heat. It did have power and a toilet at the end, but not hooked up to any type of plumbing. He would just dump a bucket of water in. He, in one of his times of being intoxicated, fell asleep during the winter, got frostbite on his foot, developed gangrene, or at least near gangrene. They wanted to amputate the foot. He refused. And over the next 9 months, we just pleaded with him we had housing for him. Our CHW found housing, got a good apartment for him. He would actually pay less in rent than the lot price where he was at. He refused. He didn't want to change. He questioned our motives for taking him out of this trailer, which he owned. And it really took, finally developed another infection in the foot. 8 months in, was shipped over to a larger town where, again, they were insisting they amputate. He was again refusing. And he texted our CHW about 10:30 o'clock at night saying he wanted her to help him get out of there and get back over. She called me on my home phone. We talked about it for a while. I had her call him in the hospital. She had a long conversation with him and just talked about all the good things that could happen if he just allowed us to save his life here and amputate what we needed to of his foot. And really by the end of the conversation, he agreed to accept a call from me the next morning. We talked. He agreed to the surgery and had a partial foot amputation, which really saved his life. 2 months later, he moved into housing. He's now 2 months sober in his own apartment, handicap accessible. We just finally got him a scooter, and will he relapse? Will other things happen in his life? Yes, but without the connections he had made to this CHW, I doubt he ever would have got out of that trailer, ever would have agreed to that intervention, and he'd probably be dead now. So she saved his life. I was involved. I was a member of her team, but really it was that community health worker's relationship and trust she had developed with that person that really saved his life.
Wow, what a great story. What a great story. Thank you, Chris. So Bob, can you give an example from your health center describing how one or more teams have made a difference for a patient or group of patients beyond what a clinician alone could do?
Sure. Will Kaufman is a primary care provider at our South Valley Health Center and a care team leader. He shared with me the following example of care being delivered. The patient was a 21-year-old undocumented and uninsured young man who had graduated from high school in Albuquerque and was a few weeks away from starting college when he was receiving a ride to meet someone riding on the back of an ATV. The ATV hit a bump, and he was ejected from the ATV and sustained a cervical spine fracture among other injuries, leaving him a quadriplegic. He had an extended stay at the hospital, was transferred to a rehab hospital, and a few months later was discharged. He showed up at our clinic a few days later with dwindling 1 month's supply of his 8 medications, no supplies for his urinary catheter, appointments for 3 specialists, no plan for physical or occupational therapy, and an old wheelchair completely inappropriate for the level of disability that he had. No insurance and no way of applying for insurance due to his immigration status. His mother had quit her job to take care of him, and the father was working 3 jobs to try to support the family and pay for his medications, appointments, and attempts to pay back his astronomical hospital bills. As Will stated, I could refill his medication, but literally had no idea how he was going to afford them, and was very worried that he would be shortly back in the hospital with a urinary tract infection, or worse, as a number of his medications were life-sustaining. I had a head start on at least knowing what his social needs were, as he had answered positively to 8 of the 11 social needs screening questions we ask every patient every visit at the South Valley Health Center. I connected him to our community health worker who started working on the following for this patient. The community health worker checked to make sure the patient was registered for our discount pharmacy program, found an organization in town that recycled and repaired old medical equipment, including wheelchairs, and found a motorized wheelchair for the patient. Gave the family information about food pantries to help ensure that they had adequate food, started looking for more affordable housing for the family, called the Immigration Law Center, and found out that due to a prior assault that the patient had been a victim of, that he was now eligible for a waiver and could apply for a green card. If this comes through, the patient would then be eligible to apply for insurance. Called physical therapy offices in town and found a physical therapist willing to allow the patient to spend time at the office working with him for free in between his other patients. As Will states, I was essentially powerless to help this patient, given the enormity of the medical need combined with his overwhelming social needs. He would have likely ended up in the hospital in short order. Were it not for our community health worker, it would have cost the healthcare system a massive amount of money and cost this young man his future. The patient is now a student at Central New Mexico Community College and has regained enough of his upper body strength that he can push himself in his wheelchair and transfer himself from his chair to his bed as needed.
So now we have two examples of how community health workers have saved people's lives. So Roger, do you have any other examples that you could cite about how another team member... I brought my dog.
Does that mean I'm done?
This is my dog. Other examples, Roger?
Sure. Yeah, these are very powerful examples that give you a sense of the impact on patients' lives. I too have a story, but I'd also like to attack it from the impact of the care team. Many of those in the room that are part of the health center movement participate in the Health Disparities Collaboratives. And it was about a decade ago, I believe in this hotel, in fact, I attended a meeting and a health center from New Mexico presented, and they were encouraged to bring a patient to the session. And we had been coaching, I was part of the IHI faculty that was coaching that initiative, and we had been working on optimizing the care team and talking about these changing roles. And the care team was reflecting on how great an impact this had on them personally, this new change in model, this sharing of responsibilities, this collaboration towards working with a patient, and seeing the translation of that on people's lives. And they told the story of a fellow, I remember his name was Dan, and they told this story of how he was close to 400 pounds, non-compliant, not engaged, really desperate, was almost on death's door, and how through a series of different members of the care team engaging and working collaboratively, we're able to get this person into true better standards of care. But he ended up losing weight, ended up being hired by the health center to become a promotora, and went on his journey. So they presented, and we had a storyboard round, very much like the storyboards outside. And I saw the care team standing there, and I was across the room, and he came to take his turn to tell his story in front of the storyboard. And I watched as if he was a rock star, people in the audience coming up to him and asking him and interviewing, and this big smile. And the crowd dispersed, and I saw him look up at the ceiling and just smile. And it was so captivating. I went across the room and I said, "Excuse me, Dan, I just saw you talking to these people, and you're looking at the ceiling. What are you thinking about right now?" And he said, "Oh, man." He said, "You don't know my story." He says, I was almost 400 pounds. I stopped sleeping in my bed. I was sleeping on a couch because I couldn't get in my bed and get through the door to my bedroom. And I go to the clinic, and they tell me, you're a bad person. You need to do better. You need to do this and that and this and that. And I just gave up. I just stopped. And one day I was in the clinic, and they were talking about this group visit, and this medical assistant came up and talked to me, and we sat, and something changed. I don't know what it was, but they got me into this group visit, and I lost 200 pounds. I'm now 190 some pounds, and I now manage 30 patients, and I'm helping them lose weight. And here I am at a national conference, and I'm now teaching doctors and nurses how to take care of people like me. You know what? I'm going to become one of them. I just decided I'm going to go to nursing school and now become part of the care team. That's extraordinary.
Incredible examples of sharing the care. And if anyone here thought when you walked in the door, which I'm sure you didn't, that it's all about doctors, it's clearly not all about doctors. So very briefly, so we leave a lot of time for all of you. Very, very briefly, how has ECHO contributed to your team? Chris, just a couple of sentences is about all we can have.
So, there's so many ways they help, but I think, especially in a limited amount of time, it really is what attracted me to start up with these guys, first of all, was just sitting in on one Hep C talk. I just swung through Albuquerque. I was actually had already accepted a job in Tucson, and I just sat and watched how they interacted, not only with each other, but with people coming in on video. And the amount of empathy and respect and availability and obvious devotion to really providing excellent care, but also being there for each other and for people coming in on video just really struck me. And so how it most helps my team is it helps us recognize how to be with each other and how to be with patients, to be open, to be really honest and show integrity in everything we're doing, how we treat each other, how we treat our patients, how we answer the phone, how we're dealing with other people on the phone. It's a way of being. It's a way of interacting which shows respect, humility, devotion, and I hope I lead by example. Without the devotion of Sanjeev, who obviously has put so much of his life out there, you just want to do as good a job as you can as a team, working with your patients and working with each other. So I think it's the mentoring they give us on how to deliver excellent care, how to do this work. And all the other stuff is really great. All the specialists' knowledge and all the different things really help. But I think they show us how to be.
Thank you. So, Bob, from a senior leadership perspective, tell us how Project ECHO has contributed to your organization's core mission, and what role might the ECHO project play in addressing the social and economic determinants to population health? That's a long question for a short answer.
Well, our mission at First Choice is to increase the health and wellness of the communities we serve. Involvement with the ECHO project has certainly provided access to needed specialty care for our patients, decreased costs to both patients and the healthcare system by providing specialty care in a primary care setting, improved patient compliance and outcomes due to ease and comfort of delivering care from within the security of the patient's medical care home. It's enhanced provider recruitment and retention by increasing professional satisfaction, and increased staff retention by increasing work satisfaction and providing opportunities for career advancement. Just as the ECHO project facilitated a collaborative relationship between FQHCs and the Institute of Health Improvement to address flow issues in the outpatient clinical setting, the Project ECHO model can be utilized to connect the care delivery system to those innovators addressing social and economic determinants of health. Innovators involved in education, job creation and manpower development, housing, food sufficiency, child development, community and environmental safety can be brought in a collaborative relationship with health delivery systems to identify viable ways to expand and sustain the social and economic safety net.
Thank you. So, Roger, what's been your experience with Project ECHO?
So my role with Project ECHO is involved as IHI faculty to a project with a group of health centers, including Bob's, on workflow. So it's testing a quality improvement model through an ECHO framework. And there's really two key observations that strike me. One is the rare opportunity for shared learning of the care team. Often we'll send a physician to a conference or a nurse to a conference or a social worker, but everybody's in their silo. And this is an opportunity for the whole team to learn at the same time. And I think that has a very powerful dynamic in terms of teamness and building the team and that continuity, that spirit of work. And it raises a question in my mind whether turnover of staff on those teams is less than the rest of the organization. And the second is that with a weekly case conference like this, it moves quality improvement into daily work rather than the project of the month. And that also is a very different way of approaching and driving improvement that I think is proving very powerful.
Thank you. And I've been somewhat disappointed that I haven't been able to use my chimes yet. But I may have a chance with all of you. So I want to ask your permission for something. Since this is scheduled for 11:05 to 12:05, since we started at 11:15, do I have your permission to go a little bit longer than 12:05? If you don't agree, of course, you will leave at 12:05. So, questions from all of you. And if you could say who you are, where you're from, and if you have a particular panel member you want to address, please say that too.
Does this work? Yes. I'm Mike Lewicki. I'm a physician in Albuquerque. My interest is in osteoporosis, and what I want to do is prevent fractures. And to help to do so, I've directed Bone Health ECHO, which has been running for about 6 months. Osteoporosis is an example of a chronic asymptomatic disease that can have serious consequences. In the case of a fracture, that can increase the risk of disability, death, and be very expensive. A hip fracture might cost $40,000 to $60,000 in direct healthcare expenses. So my question is, how do you use the FQHC teamwork concept to address a chronic asymptomatic disease? In the case of osteoporosis, this may not be very glamorous from the point of view of the patient before they have a fracture, but they need instruction and in the balance of benefits and risks of treatment. They need fall prevention care. They need follow-up to assure adherence to therapy. And this may be a similar issue that comes up with other chronic asymptomatic diseases. So how can you deal with that using your teamwork concept?
So I'm going to ask Chris, as a clinician, if you have a patient with osteoporosis and either fractures or potential fractures, how would you do this differently with your team than if you were just taking care of that patient by yourself, and how could the care be better?
So dealing with, again, it depends on who you're talking about. There are people with an amazing amount of family support and are very educated and accessing Google sites every day on all the things they should be doing to get better. But a lot of the patients I have dealt with over the last 20 years, it's a matter of, one, finding out if they're capable of taking care of themselves. Do they understand what they need to do? And then is there an ability to kind of decrease the chaos in their lives that distract them from their health issues? Is there an ability to kind of help them impact those? If that person is being evicted out of their apartment every 3 or 4 months, if they can't have good access to food, if there are other family issues or addictions issues that are going on that are getting in the way of their other health issues, then those are things the team can work on with them. So I think it's understanding what the patient's reality is. What are they dealing with besides that osteoporosis thing, which may be in their top 3 and it might not be in their top 10 as far as things they want to prioritize on. And they might be realistic in where it's at as well. So it's the team helps assess what is going on with that patient that you're not finding out in the 15-minute visit, and then come up with a plan to help them address some of those issues.
So there are not too many patients that just have one issue. There's usually a lot of other issues, and other people in the team are probably better able to deal with those other issues than a provider. Another question. By the way, I can't see a thing because the lights are so strong, so hopefully...
Good morning. My name is Sean Mathis. I work for the Legislative Council Service here in New Mexico, so I'm a legislative staffer. And and I'm not a clinician, so here's my question for you. My takeaway from your presentation this morning is that relationships are everything, and particularly the relationship between the patient and your team. My question is, how susceptible are federally qualified health centers to network narrowing? How, because of either your patient mix or your special status as a federally qualified health center, is it likely that a patient could lose their team through network narrowing, which seems to be pervasive not only in New Mexico, but across the nation?
Thank you. I'm going to give that question to Roger, if that's all right. Roger?
I'll team up with Bob here. It's the Wild West, and appropriate being in the West here in healthcare. All the rules are changing, and the bottom line is health centers have to compete in the new marketplace as if they're an academic center or private practice. They're all competing for patients in this new world, especially as we start to move into accountable communities, accountable whatever label you want to use, where those that are buying services are going to bid them out to groups that are willing to take care for them. And that changes all the rules of the game. So yes, that is a challenge, and it puts an onus on health centers to develop the systems and acumen and wherewithal to be able to compete in this new world.
I think you've covered it. Or am I on? I think you've covered it, Roger. It's a competitive environment in which we operate today, and certainly we experience the financial and other constraints that a private practice would experience as well. So we bring, a team initiative towards serving clients to try to address the myriad of needs that they have.
And just as a word of optimism, I think federally qualified health centers are the best positioned to compete in the new market. And those that are doing that around the country and very aggressive at changing their model are doing well in many of these new environments, and in fact helping to shape the environments. Oregon's a great example where the health centers are really helping to reshape the landscape in the state.
So I think this question is really relates to team stability. I mean, patients really want to know their team. They want to be on the same team. The team needs to work together to begin to really be able to develop itself as a team. And if all of a sudden some regulation creates a rift and the team has to change, it's bad for the patient and it's bad for the team. So I think that question is really important, something to worry about. Another question.
I have a question. Is that on now? I'm a family doc at one of the community health centers in town that Bob happens to be CEO of. But yeah, I love the talk about team-based care because I think if anyone grasps that concept, it's providers and staff that work at community health centers. But I think one of the struggles for community health centers is always not who do we want on the team, but how do we afford to hire people that are going to be able to do those things on the team. And love to hear some comments on that. I know we struggled with that a lot, and the concept that you mentioned of going to the lowest denominator really is part of doing teamwork. And I know Marcia Sauer, I saw in the audience here, she helps coordinate a group of patient care facilitators, which really were just, each site picked the best MA that they thought can do some patient care talk things. And it's amazing to watch how that made a difference, for instance, on A1C levels in diabetic care. But I'd love to hear something more about how do we keep on trying to generate the dollars to create the teams that we know we need to do the care.
Thank you for that question, because clearly if you don't have people on the team to share the care with, you can't share the care. So I think, Bob, you probably worry about this every day.
Well, you know, it's always a dilemma identifying revenue streams to support the cost of salaries. A good example here in New Mexico, we've experimented with community health workers. They've been called promotoras, doulas, community health representatives for many, many years. And I don't think there's any question the value they bring to the patient visit. The issue has been there have not been revenue streams to support the work that they do. Here in New Mexico this past year and a half, we've been involved in a study sponsored by Blue Cross Blue Shield and Molina Healthcare to demonstrate the impact that community health workers have, not only on patient outcomes, but also on cost savings to the system. We're hoping that that data is going to be used at a state level to pursue the reimbursement for the services that they render. But it's a dilemma, Dr. Sava, as you know. We've struggled with this for many, many years.
Roger, do you have anything to add to this problem?
I think one of the challenges is we often make changes to our care model, but don't think through the implications from the business case perspective, and how is this actually translating into a better, more viable and sustainable position for the organization. So we have to really work with our frontline staff in understanding the economics. What would be the impact of adding one visit a week, for example, in terms of cash flow for the organization? What happens if you move that to one visit a day? And what would have to change in order to get there? How would you have to spread the work differently? And being able to feed back the results of their impact also on the revenue stream so that people see that this is moving in the right direction. Secondly, really looking at the new marketing opportunities. Health centers in West Virginia redid their model, and reimbursement wasn't changing the environment, so some of them began going directly to employers and contracting for primary care management fee on a monthly basis, so a new revenue stream that wasn't there before. I hear health centers where Medicare is often a small part of their caseload, and Medicare's recently, as of January, introduced a new case management fee for the complex patients. Well, a lot of health centers say, it's just not worth going there because we have such few Medicare patients. Well, in fact, if you look at the economics, even at 10% of your population, it's a significant amount of dollars if you really take advantage of it. So there's more to the puzzle that needs to be figured out, but leadership working with the frontline staff and understanding the economics and driving those can begin to move the dial.
Sure. Let me say one thing. There's a health center in San Diego that the medical director 20 years ago decided we need 2 medical assistants for each clinician so we can really share the care. And basically, he could pay for an extra medical assistant per clinician by having a clinician see, I think it was like 1 or 1.5 extra patients per day. So you can calculate that out. Now, we know that payment reform is the much better way to deal with this issue, but even under fee-for-service, it is possible to create a business case.
I'm fortunate enough not having to deal with strictly the financial end of it. You guys do the hard work, but I also think that I'm blessed with a CEO who really understands the mission and the need. And what we try to do at our clinic, and especially in Vegas, but throughout the system, is understand the needs of our patients. Then we come up with what are some of the things we can do. The Echo Connection, I'm just finishing up a 3-year program in something called Echo Care. We found a model that works. So we know what the need is of these more complicated patients. We know a model that works. And now we have to figure out, how do we pay for it? But it's not like, are we going to do it? It's not, is Echo the model that we want to pursue? It's how robust could it be? And how do we fund it along the way? And so now we're doing that. But we're not doubting that we need to do this. And I think Sanjeev and other speakers have already talked about the fact that this needs to get done. And some of this, a lot of agencies and MCOs and other things might be slow coming to the table to help us solve this problem, but that can't stop us from doing the work. If there's a need and we know how to impact it, we need to do it. That is our job. That's our role. That's why we're here. And hopefully, sooner rather than later, the payers out there, the MCOs and the other funding sources are going to catch on with the fact, maybe because of good arguments and good approaches, but that can't slow the work we do.
Any other questions? I think we have time for maybe 2 more questions.
Yeah, this is Miriam Kamarami. I just wanted to share a story about team-based care and ECHO. In this project that Chris was describing, the ECHO Complex Care Program, we've supported primary care teams that are working with very high-need patients with a very large multidisciplinary ECHO called the Complex Care ECHO. And it's been really interesting to see how the ECHO team and the teams on the ground have really gelled as a larger team. And the learning has been extraordinary, and it's gone in all directions. So initially when we started, the specialists, we all kind of wanted to give little speeches about the organ system that we are specialists in. And over time, that's become less and less common, and instead the specialists are much more focused on how can we meet the needs of the team, the learning needs, the specific question that's being asked about. We've also, over time, seen a real shift where the specialists have become more and more aware of the value of what the community health workers in particular bring to the table. And we'll hear specialists say things like, well, there's not really any point in addressing the kidney disease until we get this person housing. Or let's not worry about a low-salt diet when this person's eating from a food pantry. Let's figure out how to get them a stable source of food, and then we can start to address these issues. So there's been so much learning going both ways and so much really wonderful collaboration in that clinic. It's been quite exciting to see this huge expansion of the concept of teams through that ECHO.
So another thing that ECHO has done is taken the primary care team. You start with a little teamlet, and then you have a team around the teamlet. But with ECHO, you have also specialists who are really part of the primary care team because they're right there in the discussion when you have an ECHO clinic going on. So ECHO has really expanded the team role within primary care. Is there one more question? Silence? Okay. So let me just sum up very briefly. To have high-performing teams, all team members have to enhance their skills to the top of their scope of practice. Otherwise, you can't really share the care, which requires training and mentoring. ECHO can really help by offering excellent trainers that most FQHCs don't have or don't have the funds to support, and then mentoring team members through case conferences. Team members don't have to travel somewhere to get the training. So the core of the ECHO model really is case-based learning, which helps teams manage their most challenging patients and improves the quality of the care they offer to all their patients. Now, one can't really learn about teams from a panel. You learn about teams by doing it. And with ECHO, ECHO is all about doing it. So all of you go out, have ECHO part of your whatever system or whatever clinic you work in, and build your teams around ECHO and with the help of ECHO. Thank you very much, and have a good lunch.